I always encourage my patients to lock their valuables up. Because sometimes you get moved from unit to unit to unit, things can get lost, and we never want our patients. I always encourage my patients to lock their valuables up. To lock it up. Sometimes you get moved from unit to unit to unit, things can get lost. And never want our patients. I always encourage my patients to lock their valuables up. To lock it up. Sometimes you get moved from unit to unit to unit, things can get lost. And never want our patients. I always encourage my patients to lock their valuables up. To lock it up. Sometimes you get moved from unit to unit to unit, things can get lost. And never want our patients. I always encourage my patients to lock their somewhere in the security department.
Okay.
I believe. I don't even know where the safe is, but I'm assuming it's in security. It's on site.
Okay.
So, but it's not in the room.
Okay.
Yeah, to lock it up. Sometimes you get moved from unit to unit to unit, things can get because trauma patients would, it was like an $80 bra, and she was furious. And it's like, sorry for saving your life. $80 bra. You have to kind of get to things when we're doing CPR and stuff. So it's kind of what you value, so what you feel is valuable and what the patient might feel is valuable. Just always ask them. Always, always, always. Even if you don't think that the patient has it, check them for dentures, for bridges, just bridges that you can take out, and hearing aids. Okay, because those are super expensive, and patients lose them all the time. So, or grandma will get admitted at 3 o'clock in the morning by rescue squad from home, and now she's eating breakfast at 9 o'clock in the morning, and she goes, I know I brought my dentures with me. And it's like, not on the list, they're probably still in a cup at your bedside at home. So we need to make sure, and if it's not documented, then we don't have anything to go against it, and if she's saying we lost her dentures, then we lost her dentures, and right there's over $1,000 to get fresh, brand new dentures. Same with hearing aids and dentures. So just always make sure that, if at all possible, a lot of patients have contacts in. We don't have little contact holders or anything like that. What we can do is get 2 specimen cups filled with saline and help them take their contacts out and put them in. But if family members can bring them glasses, that's very helpful. Because in the hospital, the last thing you want is everybody's fingers touching your stuff going in and out of your eyes. So I always encourage patients to switch out to glasses if at all possible. So right now our COVID visiting hours are still in effect. I believe it's from 11 o'clock in the morning till 8:30 at night. So if throughout the whole house, we really don't want any family members spending the night. We still have COVID restrictions. Unless you have a pediatric patient, if they're considered a pediatric patient, they can have a family member, one of the parents, guardian, who's ever in charge of their care, can stay with that patient. That is not, we have not restricted that. Prior to COVID, we had 24/7. So hopefully one day we can get back to the 24/7 visiting. Sorry.
Should you go first? I was just going to say, what about end-of-life care?
End of life, we still will allow for that. We just don't want a lot of people. Usually we just want the real immediate family.
Are they able to stay the night too, or not?
They can't stay for prolonged periods of time. They can take respite breaks down in the cafeteria, but there's no place for them to sleep. They can't sleep in the room. And when, especially like in ICU, it's very restricted up there. We will ask the family to step out if we're doing some sort of assessments or something like that, or change a shift, just because of HIPAA issues. They give report right out in the open all the time, so we really don't want a lot of family members in ICU that shift change. Go ahead.
Going off of the pediatric thing, what about patients who are on the spectrum and have a
caregiver that's staying with them? They can stay.
Okay.
Yes. Like from Sunshine or from, what's the other one? Bittersweet Farms or something like that. If they have a caregiver, absolutely, because they are phenomenal with the patients. And it's actually so much better for the patient. They're used to that caregiver's voice and that caregiver touch, that when we're working with those patients, it's very, very anxiety producing if they don't recognize who you are. They usually go backwards in their healing instead of going forward. So yeah, we always try to have with that patient population, they're
trying to do something in here? He's been in here like 3 times.
Yeah, he's working with the stuff.
Oh.
You need in here, Derek?
No, we're just making sure that
Okay.
you're explaining something.
Oh, okay. Yeah, you see all that stuff sitting out over there? Yeah, that shelf broke and all that stuff came tumbling out and ruined a lot of our equipment.
Yeah, he's been in here like 3 times, and
Yeah.
they're like, does
Yeah,
he need
they're
to be
they're
in
desperately
here?
trying to get stuff fixed. So it did thousands and thousands of dollars worth of damage with that
Wow.
shelf.
Wow.
So I don't know. First of all, wouldn't you think that you wouldn't put something on the shelf that was super, super heavy?
Right.
Like, yeah, okay. That's gonna be a bad thing. A read back with our medical orders, this is a must. Anytime that you are getting verbal orders, we always encourage the physicians to put orders in themselves, okay? Because then that cuts down on a lot of medical errors when they put their own orders in. But if for some reason you're getting a verbal order or a telephone order, it is an absolute must to read back that order. So, because so many things sound alike. Yesterday in EKG class, I was talking the difference between a BNP and a BMP. They sound really the same, especially over the phone. Again, a lot of our physicians are not, English is not their first language. So sometimes it just might not sound what you think they're trying to say. It doesn't sound exactly the same. So make sure that when you get your list of orders that you read back and you tell the physician, okay, is that the end of the orders? Because I'm going to read these back to make sure that I'm accurate with everything. I got everything that you want. Some doctors will say, I don't have time for that, blah, 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 blah. I just start talking. Okay? And if they refuse to, maybe they say they're too busy or whatever, then I document that. Read back attempted, physician stated too busy and hung up. So that there is ever a problem with whatever you're ordering, that you're covered. Because they can easily say, I didn't say that, I didn't say that. So always chart that you read back your orders. And that's at any institution, anywhere, in nursing practice, it's always best practice to read back, even if it's just 1 or 2 things. It's like, okay, is that the end of the orders? Yes, sir, let me go ahead and read back those orders and make sure I have everything accurate. Yes, ma'am.
And half the time they're doing 5 things at once. So.
It doesn't matter, you're reading back.
No, that's what I mean.
Oh, yeah.
That's what I mean. So they
Yeah.
may give you something.
Yeah.
Oh no, that wasn't for that patient. I'm sorry. Wait.
There's a lot of medications that sound the same. There's a lot of, lab tests that sound the same. So it's just always best practice to read back your
They'll
orders.
change their mind sometimes. They'll be like, well, I want 40, I want 20. Actually, yeah, I want 20 on that, not 40.
Yeah. So, and then just clarifying your medical orders, making sure that what they're saying, is it really for that patient? Because sometimes they might be thinking of a different patient and giving you orders. And it's like, why are they ordering all of these heart medications on my patient? They're an orthopedic patient and they don't have a heart history. So think about why this patient's getting this medicine, and maybe it was an error on their end. That's why we read back things and making sure that we have the right patient for the right medications. Computer downtime. For all you guys that are working nights, wake up. This is super, super important. I almost swallowed my gum. Every night, I know I'm a freak sometimes. Every night at 3 a.m., the computers are going to go down for about a 10 to 15 minute time frame. Every single night at 3 a.m. What computers go down? All of your charting. So therefore, you can't scan medications because your scanning is going into your charting. You can't DOS anything because it's going into your charting, and you can't do any type of charting on your patient assessment or anything like that. So, I recommend that if you're especially new here to UT, everybody has our you all have cell phones, we all carry them with us, that you set an alarm for like 5 minutes to 3. So that your phone is going off. So if you are doing something at the computer, you have to save it. There's no autosave with McKesson. If you are charting an assessment and you walk away, you can very easily lose it. If you're charting and the computers go down and you didn't save it, it's gone. There's no way to retrieve it. So you could have sat there for 45 minutes with grandma that told you everything about her past medical history for the past 40 years. And you got that all in here and you didn't realize that your computers are going to be going down. Poof, it's gone. You'll do that once or twice and then you remember, but I'm trying to so that that doesn't happen to you. At the bottom of the screen, on every screen, in a really small little circle, when it's 85 seconds till the computers go down, this little screen pops up and it'll start counting backwards. Just to kind of also help remind you. But sometimes, you can be doing something, walking around the patient's bed and completely miss it. If it gets down to 20 seconds and you haven't saved that information, you're probably not going to be able to save it, because there's a delay between the time that you hit save till it actually saves your material. So when it's just a few minutes before 3, or even as you're doing stuff, just every now and then just stop and save it. It's always best practice to do that in case you get pulled away, a code gets called, and then you just kind of like fly out of your seat and completely forget to escape out of your charting, so that you always have what you're charting. Okay. So it's awful, but just to make sure that you know. Now, on a very, very rare occasion, the computers may stay down longer than that 10 to 15 minutes. They will announce it at the beginning of the shift. Say, hey, the computers are going down from 1 a.m. to 3 a.m. And you go, oh, that's a long time. If it's going to be a prolonged period of time, they will print out all of your med sheets on paper. And then you'll just be marking it off on paper. If it's a prolonged period of time, we have paper for every type of charting. Believe it or not, years ago, we didn't have computer charting. Everything was done by paper. So we have all of those paper pharmacy requisitions, lab requisitions. We have full charting, for your assessments, all that kind of stuff. So if it's going to be down for more than like 3 hours, I always opt to pull out that paper and start doing all of my charting on paper, because I don't want to stay till at 6 or 7 in the morning when the computers come back up and I have to do all this back charting. I want to go home at the end of my shift. So I usually will pull those papers. Again, maybe once a year at the most will our computers go down for a prolonged period of time. But every unit has a box with all of our paper charting. Just to let you know that we nationwide, I don't know if you guys are aware of this, it's more than Blue Top now, it's all of our tubes, our blood tubes, are in national back order. We're running out of lab tubes nationwide. So I don't know, it must be coming from Indonesia, from China, from somewhere over there, because we can't get the rubber stoppers for our lab tubes. So in the ED, they still can draw labs themselves, but it's very much regulated. Don't be surprised if you get phone calls from labs saying, does this patient really need to have this potassium drawn for the 3rd time today? Because they don't want to keep wasting all of these lab tubes. They want the docs to be very careful of what they're ordering to make sure that it is needed. If it's needed, absolutely, but lab will come up and bring the tubes with them. They don't want tubes on the units getting wasted, getting forwarded, whatever, because it's a big problem nationwide. So we also have a lot of medications that are on back order. So all of our emergency drugs are no longer on back order. About a year ago, we ran out of D50. D50. We had no D50 in-house. If our patient's blood sugar was in the 30s, we were hanging D10. And we're running IVs D10. For a long time, we were really low on epinephrine. We were making our own epinephrine syringes for codes. So we had it in ampules that we were pulling out during codes and mixing a lot of our own medications. So it was, and bicarb. You'll notice in the code cart we only have 3 bicarbs. We have enough bicarb in-house. It's still on national back order, but they just don't want to put a lot of them on code carts because we don't want it to expire. So you have 3 rounds of bicarb on the code cart. You also have lots of bicarb in our AccuDoses, and if you're going to need a lot more, then we just call pharmacy and they'll send it up. So isn't that crazy? All of these drugs, and it's the simple generic drugs, and the reason why they keep going on back order is because that the pharmaceutical companies don't make any money off of them, so they don't want to produce them. But the government now has kind of forced them to start producing some of these very needed generic medications because nationwide we were running out of them.
What about nurse draws?
I'm sorry?
What about nurse draws?
Nurse draws? Usually the lab will bring you the tubes.
Okay, because I'm in almost
In
half
in
of
ICU, yeah, you guys might have access to some, but usually they'll send the tubes up or they'll bring them up.
mine. Okay.
Mhm.
Or I call down and say, hey, I need, these tubes for, okay.
So, and I'm all about, isn't that true? It's like, oh.
Uh-huh.
So, advanced directives, that's what we mean by an advanced directive. It is like a living will, durable power of attorney, or a DNR status change. Are all of you familiar with the state of Ohio? DNR, okay. Because that varies from state to state, so DNR. I will go through each one of these to help you understand, because you're gonna see one of them and think, that's the craziest thing ever if you're not used to Ohio, because a lot of states don't have what's called a DNR-CC arrest. You have most people are just a DNR or full code. Well, we got a great big gray area. It's very difficult to work with, but an advanced directive is just a written statement of a patient's wishes if they are not able to make their own decisions, if they can't communicate, then that's when that medical directive goes into effect. So if your patient is fully alert and oriented, maybe it's just because they're older, really, whoever that's been designated as the POA really doesn't have any right in that patient's care until the patient cannot take care of themselves. That's when it goes into effect. But a lot of family members think, well, I'm the POA, I'm going to make the decisions. Well, really, we have to listen to the patient. So the patient can tell us whatever you're saying. So upon admission, we always ask our patients if they do have an advance directive. We want a lot of patients. We want everybody to have an advance directive, because you just never know when you are going to be incapacitated and not make those decisions for yourself. It's really hard on families if there's not one clear-cut person making those decisions, and it can take days and days for some decisions to be made because maybe families aren't agreeing. And then if they do have a copy with them, we make a copy of the original. Usually some patients bring the original with them to the hospital. We'll make a copy and give them the original back, but we'll keep a copy on file so that we know if they say, Mr. So-and-so is the POA, then we have proof. Always know with power of attorney, there's two different types of power of attorneys in the state of Ohio, and I'm pretty sure it's nationwide, but I can only talk to the state of Ohio. You have a POA for healthcare and you have a POA for financial. They're not the same. You can have the same person be both, but you just can't say, okay, it says POA for healthcare and yeah, it's for both. No. So if your paperwork is POA for financial, that person can't state that they're the POA for healthcare. You have to have documentation, POA for healthcare. There's two different kinds. So there's financial and then there's healthcare. We have two different types of do not resuscitate orders, a DNR-CC, which means comfort care, which doesn't mean we're not going to treat. Of course we're going to treat the patient, but we're just not going to do any heroics for that patient. Or a DNR-CC arrest means we are going to do everything for that patient. They are going to be a full code up until the point that they arrest, and that's when we stop. So if your patient is septic, we're going to be super aggressive with them. We can start them on antibiotics, start them on pressors, do all different types of treatments, whatever. But if they respiratory arrest or cardiac arrest, then we stop, and then we're just going to let them go. They turn into a DNR-CC.
Just out of curiosity, so what if they say come from Indiana or Michigan and they
Doesn't matter.
It doesn't matter. How would we chart that though?
We have to get an order.
Okay.
Even if they come from the LTAC down the street, we don't care in the state of Ohio if you already have a living will or durable power of attorney or in any type of that. When you come into our ED or come anywhere into our hospital, we have to have an order for that status, whether you're a DNR or DNR-CCA.
So you're a full code up until the moment we have that documentation in our hand.
Yes.
Okay.
Preferably in the medical record.
I was just
Yes.
confused because Michigan doesn't have the DNR-CCA
Yes.
part, so it's
Yes.
how does that
That's-
transfer when they come down here to get treated?
Nope. Like I said, even if they're at Ash, right down the street, if they're a DNR, CC there, when they come to our ED, we have to immediately get that order from the ED doc or whoever. It can be a nurse practitioner, it can be a PA, and it can be an MD that can give that order. They can give it to you over the phone, but usually then you have two nurses accepting that order if it's over the phone. But we have to have that order. So if for some reason they made it through the ED, they're coming up to the floor and nobody noticed that this patient's a DNR, then we need to hurry up and get that order into the patient's record. Okay? If not, then we have to treat that patient as a full code and explain that to the family that patient was a DNR in the nursing home. They came in, nobody realized that there was a DNR CC, patient coded, we did CPR, intubated him, did all this kind of stuff, and then we realized that there was a DNR order. Yeah, that's a big problem. So we're always very on top of patient code status.
So at that point, what would you withdraw the intubation, or will you just wait till they code again?
That is up to the managing physician,
Okay.
but it has to be reported to the family.
Okay.
What happened? Absolutely, it's a medical mistake. So always know what code status. I'll go over what the difference between the two are in just a minute. So a DNR is to comfort care only. Again, we can give patients medications, we can give them pain medications, we can give them fluids, we can give them nutrition. We're just not going to do any type of heroics. We're not going to do CPR, we're not going to defibrillate, and we're not going to intubate. We can do BiPAP, we can do high flow, because those are non-invasive. Anything invasive we can't do. We can't do an LMA, we can't do any type of intubation, but we can do CPAP, BiPAP, and high flow with DNR CCA patient or CC patients. But we're not doing, again, any type of CPR or intubation of the patients. Again, the DNR order does not go into effect until it's signed and in the record, and it doesn't mean that we're not treating the patient. And a lot of families have a hard time with that because they think, oh, a do not resuscitate, that means you're going to stick grandma at the end of the hall and you're not even going to turn her or do anything. No, we have standards of care. Absolutely, we're going to be on top of grandma's care. Just like every other patient. We're just not going to do any heroics for her. The patient that has a DNR order, the family cannot demand that order be changed unless it's the POA or the patient themselves that changes that order. It can get changed back and forth as many times as the patient wants. Let's say the patient is fully alert and oriented, they have a history of cancer of some sort, they come in with a DNR and they say, you know what, I think I want to go back to a full code. Absolutely, we can put you back to a full code, and maybe as time goes on, we'll say, maybe I want to be a DNR again. No problem, we'll just stick that then back in the record, and now your patient's a DNR. They can go back and forth. We don't encourage that, but they have that right to change the code status, whether it's the patient, and if the patient can't make that determination, then the POA. But let's say, your patient is a DNR CC, your patient is dying, and maybe there's a family member that comes in that disagrees with that and demands that we change that code status. We cannot do that. So usually we have to really sit back and talk with that individual and say, these were the wishes of the patient. We have to abide by that. So, and sometimes that's really hard.
What if families start CPR?
There's nothing that you can do about that.
Okay. I just didn't know, because sometimes family would just
Yeah, they do.
their last hope is do it themselves. I just didn't know if that was they would allow or how to handle that or just.
I've never had that happen. You can talk to them, encourage them, but by law, they're a DNR.
Right.
For us to do anything, we're bound by the law.
Okay.
So we can suction, we can give oxygen, we can control bleeding. Absolutely, we're going to be turning our patient every 2 hours of medication. If they want, we'll start contacting hospice or home health, anything, so that when this patient's ready, we can have them go home. DNR CC arrest. This means, again, your patient, we are going to be uber aggressive with these patients, just like any other patient that's a full code. They are a full code up until the point that they respiratory arrest or they cardiac arrest. We will not intubate these patients. We will not defibrillate these patients. We're not going to do CPR on these patients, okay? But we will give them antibiotics, we will, if the patient is requiring 4 pressors to keep their blood pressure up, with a mean arterial pressure greater than 65, then that's what we're gonna do. It usually isn't gonna last very long if they're on that many pressors, but we will do all of that up until the point that they arrest.